So I'm pleased to welcome Dr. Jemsek today to Lyme Disease UK. He's a board-certified physician in infectious disease and internal medicine, and Dr. Jemsek practiced medicine for more than two decades in North Carolina and diagnosed the first patient in North Carolina with HIV/AIDS in 1983. In 2000, he founded a clinic specifically with the goal of serving patients with HIV/AIDS, in addition to practicing general infectious diseases, including Lyme borreliosis complex. His practice soon evolved as he began treating more and more patients with Lyme borreliosis complex, which is also commonly referred to as Lyme disease. He then moved to treating solely Lyme disease patients in 2005 and founded the Jemsek Specialty Clinic in Washington, D.C., which officially opened its doors in January 2010. The practice has grown with an addition of 4 physician assistants and 2 nurse practitioners, all dedicated to serving patients from around the world. So welcome, Dr. Jemsek. It's an absolute pleasure to have you here to discuss your approach to treating for our UK patients.
Well, thank you very much, Sarah. As I mentioned before we went on air, we love our UK patients and patients from Europe. We certainly understand the sacrifice that they make, and it's a shame that they have to make that sacrifice. So, the hope is that one day there'll be qualified physicians all over the globe to serve what is a growing and explosive epidemic.
Indeed, that would be amazing if people didn't have to travel so far to seek treatment. So I guess really, could we start by you explaining a little bit about your treatment philosophy and particularly how it might differ from other doctors that treat Lyme disease?
The treatment philosophy, of course, has evolved, and we're continually learning. And I think that the key notion here is something that's so basic that it is, perhaps isn't worth mentioning, but yet it's worth mentioning since it is fundamental, and that is to listen to the patient, learn from the patient, and touch the patient. And in doing so, and I learned this from my HIV practice, and I've learned a great deal more, and I keep learning from this very complex illness. And that makes us different because we find things that other people don't find because we touch and we listen. And that sounds oversimplified, but it's quite real. We've been criticized, the people that treat, the doctors that treat this illness have been criticized as saying, well, it's a disease with lots of complaints, but no objective findings. Well, you're not going to have objective findings if you don't touch the patient. And can you imagine the academics writing these worthless articles, actually examining the patient, taking detailed history? No, it doesn't happen. So our approach is to look at this. I believe I was the first one to understand that in the vast majority of patients, perhaps 95% or more, there's one exception we can talk about later, we're talking about a multiple infection process, so a polymicrobial infection. I think as a background that you understand we have 500 trillion organisms in our body, most in the gut, and innumerable species, and I think that number is growing exponentially as we learn more. And as the host, everything's symbiotic and we're all at peace until there's a disruptor or unless there's an immune problem. I do think that most of the people walking around the planet have a spirochete. And I'm talking about the Borrelias spirochete, not the dental commensal spirochetes. I'm talking about a potential pathogen or a pathogen. So I think most of us carry a spirochete. And the approach would be that, there are a handful of infections that we identify, and there are probably another dozen infections that we don't really know about and don't identify. But it seems if we treat half a dozen of the targets and we do it in a sequential and intelligent way, we have success. And of course, the spirochete is always the main goal. Now, what triggers infection? Well, I think it has to do with a number of things. It can certainly you need the other infections, the co-infections. And we understand that. So we're treating our patients as if they have multiple infections, and we prioritize our treatment. And I guess the main thing that people don't understand and don't appreciate, which I appreciated many, many years ago, was that babesiosis is a not common, but uniform part of the picture. And for whatever reason, when you get a profile with the Borrelia species, and of course we have no idea how many different species are involved in one person because our testing and markers are visible. But anyway, there's this Borrelia species spirochete, and you have babesia, you have opportunistic infections like you do with HIV that occur with mycoplasma and chlamydia pneumoniae. You have proteomyxoma, FL 1959, which was described a few years ago, and you have Bartonella, our friend Bartonella, and there are different species involved, and it's difficult to speciate those. As I said, I think there are a number of other pathogens, but essentially you're into a situation once there's a critical point, the co-infections and the immune response work in a way that allow the spirochete to drill, be liberated, if you will, and drill wherever it wants to go. And of course, several of these pathogens love tissues in the central nervous and peripheral nervous system, which is a distinctive clinical pattern. So I don't think the human species has ever seen anything quite like this. In fact, I'm sure they haven't. Destructive disease. So our approach is to look at the fact that we need to do appropriate therapy. We understand the toxicity of therapy, and we must, and we take advantage of the life cycles of these organisms, which are slow replicating. So we don't treat every single day. We treat with combinations, much as I did with HIV. I think everyone knows the story of HIV and how monotherapy or single drugs, one after another, failed and resistance developed. It's not, so in this case, it's not so much that we have a genetic cloud with multiple mutant organisms evolving like in HIV/AIDS, where we found that we had to do a cocktail. And so in 95, we developed protease inhibitors were developed. And we had a cocktail, and that turned the table. Of course, that's been a mantra for treatment of HIV/AIDS since that time. So I adopted that approach, using multiple therapy, but yet pulsing, so the patient isn't exposed every day. And understanding that there's so much inflammation in the body that we have to do it in a slow and prudent way. So we start slowly, we build up, and we prioritize our targets, but we always treat the spirochete throughout our 9 to 15-month programs.
No, that sounds absolutely sensible. And do you believe that everybody can recover?
No. Unfortunately, I don't. There's a subset of patients who are most difficult, which we should talk about later, and that has to do with the motor neuron predominant affliction.
Yes.
But having said that, we've had numerous patients do very well, and we don't give up. We don't give up. We have certain criteria to treat a patient. We won't treat a patient unless they meet our criteria and they're stabilized. So I think most of certainly my patients and many others know that we take a while to stabilize the patient. And I sort of liken it to the metaphor would be, would you rather take off in your airplane from the ditch or from the tarmac? And so getting the patient stabilized allows the immune system to have a chance to do some orderly reconstruction.
Mm-hmm.
And we take away some of the stressors, and it's absolutely important. And one of the most important prerequisites is to have support. It's, folks that are afflicted with this awful disease absolutely need support. They need to know, someone needs to know what they're doing every day, what the goal is, address their needs and changes, and be in contact with us if it's necessary. A lot of our patients can't verbalize very well. They can't process. They can't talk. And it goes from a range of just, advanced neurocognitive issues to being bedbound. We've had patients who I didn't think would recover, and yet we keep going and do, I would say, modest therapy. not aggressive therapy. And then sometimes there's just a switch. And when I talk in the fall at the Academy of Nutritional Medicine Conference, I'm going to talk about a list of conditions that preclude treatment success, and how we try to identify those ahead of time and how we deal with those.
Yeah, that makes sense. And in terms of preparing for treatment and stabilising the body, other than that, the support network, what are your top tips?
All right, so I have an acronym that I have been using for 15 years plus, and it's POEMS, POEMS. P standing for pain. There are basically three patterns of pain. There's nociceptive, there is neuropathic, and then there is central or regional pain, involving different fibers, neural fibers, if you will.
Mm-hmm.
And the middle one, neuropathic pain, is like having a toothache somewhere else in your body. It's like a toothache in the middle of your back or your neck, or going down your arm, or into your belly or groin, anywhere in the lower extremities. The nociceptive pain has to do with musculoskeletal, deep pressure points, and things of that nature. It's conducted by a faster fiber, the A fiber. And the central regional pain, which unfortunately too many of our folks have, is corruption of the C fiber in conjunction with the autonomic fiber, which they travel together in the same sheath. And if both those are corrupted, then you have this god-awful situation where light touch causes dysesthesia, causes intense discomfort. It's, we call it, I simply ask the patient, do you have don't touch me pain? I can't be touched. And if you're with your spouse, or it's just someone you love and you'd like to hug, they can't be hugged. Stiff wind will put them will be torture for them. So there's no way these folks, with this kind of pain, if they have intense pain, and almost everyone does, quite honestly, you just can't. It's such a stress that you cannot. You have to mollify that. It's absolutely essential. So we do that. O in our poems is for other, and primarily it is support, but it also includes comorbidities. So if there's another disease going on, or another condition, or a bad environment, social environment, or let's say just something, a house full of mold, for example, as a trigger, we have to redress those. And then E is for endocrine. So since this disease absolutely obliterates or can obliterate the lower brain, the reptilian brain, at the top of which is housed the hypothalamus and the pituitary, there's frequent dysregulation of the hormone loops, and the most critical one is the adrenal loop or the cortisol loop. And if that's in the tank, the patient's literally at risk for death. Sex hormones are affected. They're not as important. We can address those later, but they are important. Tons of thyroid disease, lots of diabetes insipidus, where the patient's voiding large volumes day and night. Absence of vasopressin from the posterior pituitary. Reduction in MSH, which is a governing hormone and signaler, and so forth. Growth hormone is not well studied in this illness, but I'm sure it's significantly affected. It's very important in terms of preserving cell structure and cell growth. So endocrine is very important. And then M stands for mood. Someone who's afflicted with this illness, in the mildest form, they're going to be irritable and have a short fuse. They've lost their edit buttons. It's because the amygdala has been activated. That's in a simplistic way. And in the worst form, they're absolutely schizophrenic and having hallucinations. Obviously, we can't treat that individual until they're stabilized, and they can be stabilized. It's a combination of reducing the inflammation in the body through various approaches, and also using psychotropic medication judiciously. If we have an involved psychiatrist, we were more than happy to work with a psychiatrist and work together. But oftentimes we know more about the illness and this condition, psychiatric condition, than the psychiatrist. In fact, a lot of psychiatrists are puzzled by why their drugs don't work very well. Well, it's because the brain's inflamed organically.
Mm-hmm.
But on the other hand, I would say as a group, the psychiatrists are the most intuitive and ready to learn group, if you will, and because they listen to the patient. And then the last one is sleep. And this is a complex mechanism, but we have to have deep sleep. We have to have delta sleep. And that occurs generally in the first 4 hours. The best sleep is before midnight. I guess that means you go to bed at 8, which I don't. But it's really true. That's when the brain rests. The REM sleep is when the body rests, and the brain is dreaming. And what's more critical for immune reconstitution and immunologic help is the delta sleep. And so if that's totally disrupted, again, I can't treat the patient properly. So we use poems to get patients started. Now there is one other one that's for women, and that is perimenstrual volatility. Because of the change in hormones, and when the estrogen starts to drop in the premenstrual period, the prostaglandins shoot up. And in a woman who has a whole network of very susceptible and hypersensitive tissues, if that happens, everything lights up and many bad things happen. And if it happens for several days before and a couple days into the cycle, we're talking about 10 to 14 days out of the month, and I can't help those individuals either. We try to work with a gynecologist to suppress ovulation when possible.
Okay. Oh, yeah, I wasn't aware of that part. That's interesting. I do remember last year at the AONM conference in May, you saying about how even if the person could cope with the pain, because we often do cope with a lot of pain, the immune system can't, and that really hit home with me and emphasised the importance of pain relief.
Right, I get that a lot, Sarah, from patients that, well, I don't want to mask anything. I want to know what's going on, and I can handle the pain. I said, you can handle the pain, but your immune system can't.
Yeah, no, that's something that really I remember from your talk very clearly. So, obviously your approach is predominantly antibiotic therapy, but how do you decide whether a patient is best treated with oral antibiotics or IV antibiotics?
That's an excellent question. I would say, of the entire group, it's about 20% that go to IV, and there's probably another 5 or even 10%, maybe not that much, 5% who should go to IV but can't afford it, unfortunately, because insurance companies abrogate the responsibility and turn the other, look the other way. But I would say about 20%. Our criteria are based on subjective reports of cognitive abilities. And we do a simple scale of 10 being previous normal cognitive state with ability to multitask, process quickly, learn new information, and so forth. So everybody has their own 10. So it's a self-actuated scale. I'm not comparing them to you or anyone else. I say, when you were best, and that's your 10, think about that. Where are you now? And I say, 1 is brain dead, and let's just work through this scale. And so the patient will give me a number, and we try not to rely just on the patient. Often we have a companion or a spouse or a partner, and we'll ask the partner to be involved because, they have a little different opinion. We have patients that are quite stoic. We have patients that tend to be a little bit hysterical. But I would say the stoicism predominates, and so nobody likes to be sick. Nobody wants to admit that they're suffering in the way they are. So we try to get a number. If that number is 6 or less, that's profound dysfunction. And then in the same vein, in an objective way, we may order a brain SPECT scan, which we can do locally here and which I've done for many years. The brain SPECT scan is a very insensitive test, but that's nice because it separates the really bad from, the ones that aren't quite as bad. There's asymmetry in the blood flow. It has to do with blood flow, which I think correlates with glutathione in the brain, and glutathione deficiencies. And so if there's an abnormal brain SPECT scan, that's strong supporting evidence the patient needs more than oral therapy. Other conditions would be critical structures at risk, such as the eye, if they have papillitis, or if they have a syrinx, a large syrinx in the spinal cord. So the other indication, even if the brain is working okay, if they're at risk to have critical damage, critical structures. And then, of course, we work in and factor, okay, what therapy have you had? And people are all over the map on that. A lot of oral therapy, not put together very well sometimes, and then some Rocephin, because that's the default way to go. It's just not enough, and maybe several rounds, maybe years of treatment on and off, still not better. So if they have enough of the other criteria in place, we say, well, you're going to need IV therapy. And quite honestly, the patient requested. They said, I need to do IV, and I heard that you get people better. And then I think last, there are probably a couple more that I'm not thinking of, but last would be that if there's obvious malabsorption issues, which just means that this dysbiosis, which everyone has, is much more severe in this particular individual. And the way we sort of figure that out is the intolerance that the patient has to medications, to foods, and so forth and so on. So that their life is shrunk, their parameters and boundaries are closing in on them, and we know they can't absorb very well. Sometimes we do blood tests on certain drugs to see if they're absorbing. And in everyone, we try to treat the gut and approach treatment initially, at least in the last 2 or 3 years. But I would say those are the criteria.
Okay, no, that's.
And if some people come in and say, I want IV therapy, we say you don't need IV therapy, because I think we can treat you with oral therapy.
Yeah, and particularly from patients
and that
coming
happens
from the
all
UK.
The time.
Yeah, particularly if they're coming from the UK, that's obviously a big consideration to be able to be in DC for a period of time to have IV. With the you mentioned people who are very sensitive, and I think what you were saying is that where possible, you help work with their gut to improve that absorption. But if it really doesn't work, then you would look to IV.
Yeah, well, we still want the gut to work better for sure, because we have to use oral therapy with our IV therapy, or we do use it. It's important.
Yeah.
It's just with IV therapy, it's about getting drug to the site, and so that's why. If someone has papillitis or inflammation in the back of the eye, or we just know that taking oral amoxicillin is not going to do the job here. And also, one of our medications that we use is quite valuable, I think, and that's tigacycline. It's only in intravenous form. There's a misnomer around that IV drugs get in the brain and oral drugs don't. Well, that's a misnomer. Some oral drugs get in the brain through the blood-brain barrier, and most IV drugs do also, but some don't. Now, having said that, we're talking about the blood-brain barrier. All the drugs that we use, whether they get through the blood-brain barrier or not, get to the brain. They get there through vascular channels. So if they don't get into the brain, so this is another misnomer. And we recognize that, and that's why we tailor our programs to come and mop up later on with some drugs that may catch some spirochetes that are floating around in the spinal fluid. So we understand that. But the IV approach is clearly, on balance, will give the patient a much better chance for significant clinical gains, and it's much more efficient. So we may treat someone with oral therapy who can't afford IV therapy, and unfortunately, we're not at a point where I can do pro bono work, which I'd love to do, but I can't with all the issues that I have going on. And I think most people know I love my lawyers, but anyway, one day I'll do pro bono. I have a lot of other hopes and dreams as well to to build a strong physician base and access to care. But that we can talk about later.
Yeah, no, that's absolutely key. So obviously, whether you use oral or IV, you're using antibiotics to target the Lyme disease and some of the co-infections. Would you mind telling us, please, about a bit more about biofilm breakers, why you feel they're necessary, how you tend to use them, and which ones you prefer?
I'd be happy to. So years ago, I recognized, that biofilm was around, and then it was important, but I wasn't really enthralled with lumbrokinase or serrapeptidase or nattokinase, and I just didn't know how to measure those. And I would use them. I would use the weakest one, which was nattokinase, just because it was weak. Because early on, I recognized as an infectious disease guy, you have to be careful. If you're melting the biofilm, you have to kill what comes out.
Mm-hmm.
You have to kill what you release. If you don't kill what you release, it'll go from a dormant form to a wild type form. It won't be impeded by the immune system. It'll infect another cell, kill another cell, and make more biofilm. So you have microbial chaos. So I'll tell you the story of exactly how I determined to do what I do, and I do it universally now with oral and IV. I read an article put out by a surgical wound center in Montana, in the west United States, Montana, which was a strange place, but it was a nice people. And we read the article, and I shrugged my shoulders, and I said, they're using xylitol, which is a sugar alcohol sweetener, synthetic, and lactoferrin. And they had invited some PhD biochemists to come in and say, do you think we have, well, they were treating complex wounds, so you can imagine amputees, diabetics, infected sites, poor vascular supply, et cetera, very tough wounds.
Mm-hmm.
And they wondered, well, do you think biofilm might be playing a role here? And it's like, that's a duh question. It's like, we have the concept that any chronic infection in nature, not just in our bodies, will create and then dissolve biofilm and go through various cycles. Anyway, but they brought in the biochemist, and years ago, Procter & Gamble started putting xylitol and sometimes lactoferrin into toothpaste, and more recently mouthwash, because they recognized that it was well tolerated and safe, and help cut down film around the teeth, which help with cavities, and also clean the gums a bit better. So Procter & Gamble was way ahead of this, but it was never really used in medicine until the wound guys did it. And shortly after they did it, I gave them a call. I said, they told me to start slowly and work up. I said, fine. I was very skeptical, Sarah.
Mm-hmm.
I said, well, this is strange. I mean, so this true story. This is how you learn in practice. You see patterns. I think that's very important. You have to see a lot of patients. You have to really pay attention. You have to see patterns. You have to have follow-up. Otherwise, you can't learn. And so what I did, one of my best learning lessons was I had stable patients come in, people who I had treated for babesiosis and subsequent therapy, were on maintenance therapy, which is 3 days a month, or off therapy. And they came in. I said, "How you doing?" They're fine. I feel good. Everything's good. I said, I'd like you to try something. I'm using a different biofilm approach. I have no idea how it's going to work. I think you need to start up slowly on it, and let's do it. So I started doing that with patient after patient for a period of a month or so, or 2 months. And then 3 months later, or 4 months later, or 6 months later, they started coming in. It's about 30 of them. And they were all angry with me because they said, I'm sick again. Whatever you did to me, you made me sick again. Or I don't know what happened. And I went through, do you have stressors? Do you get bit again? Are you destabilized in the other ways and new symptoms, et cetera, et cetera? And no, I just feel sick, just like before. Now, the importance of doing an examination on almost all the visits comes into play here. When I examined the patients before I started the medication, I did not palpate an enlarged liver nor an enlarged spleen. When the patients came back, when I examined them at that time, their livers had expanded and were congested, enlarged, as were the spleens, in about 75%. And this is a clinical marker for babesiosis.
Mm-hmm.
And I thought, oh my God, Babesia is in biofilm. Who would have thunk that? And that's completely changed, how I approach babesiosis and what I do. So xylitol is very simple to use. I know there's people on the stevia bandwagon. Stevia is, it works, but I don't know how to quantitate it. Whereas xylitol is very simple. It's uniform, it's synthetic. Both are sugar alcohols, one synthetic, one natural. When we place a patient on xylitol, we don't do it right away because we don't want to overwhelm the patient. When we start therapy, we're just feeling things out, trying to make adjustments based on their reactions, Herxheimer's, if you will,
Mm-hmm.
or some drug intolerance or whatever. And we make adjustments. We just want to kill a few spirochetes and get the ball rolling. And there's no rush here, all right? Well, comes the fourth month of therapy or so, we initiate the biofilm program and use the lower doses and build it up to a full dose. And we treat for 4 to 6 months with combination antimalarials and other medications. Remember, I never stopped treating the spirochete. When we treat, we tell people to avoid stevia, absolutely, and xylitol. We warn them about xylitol in pets. We plead that they start at the low dose and not try to rush things.
Mm-hmm.
And as an aside, I had a few of those patients try to rush things and take 2 or 3 the amount that was recommended to get it over with, and most of them were in the bed for 3 or 4 days.
Yeah.
And these were, fairly functioning people.
Yeah, because there wasn't enough.
But at any rate, so going forward, we have a protocol which says, all right, we're going to break down the biofilm. And what I like about xylitol is it's reliable, can be titrated. It's I would say 95% of our patients tolerate it, and it's dependable. And the lactoferrin, in theory, works to help chelate some of the metal ions that are in the biofilm matrix, mainly iron molecules. But I'm sure it does much more. We just don't have answers for that. So we do it for a handful of days, and then we treat a handful of days. And I call this latter part of that the kill zone, because we've released some pathogens of all kinds,
Mm-hmm.
not just spirochetes, not just Babesia, but other pathogens. We've released them into a planktonic state. By the way, Borrelia cistiforms exist in biofilm, as well as intracellular. So we release all these things. And then they're free living or planktonic, and they're able to be killed. And in some cases, that's the only way they can be killed, because antibiotics may not get into the biofilm, and if they do, the pathogens are in a dormant state, not replicating,
Mm-hmm.
maybe 10-15%, and can't be killed. Now, I think there is an exception with fungi and protozoa, because when we use those drugs, we seem to have a die-off. If you use those drugs without biofilm, we seem to have a die-off, and rifabutin is also a possible exception. We know rifampin and rifabutin get into biofilm very nicely. So that's our strategy, and we do it starting from the 4th month until for the next couple of years, even as the patient's feeling well and goes on maintenance therapy.
Mm-hmm. And
Now, the way it works, sugar alcohol, and I'm not a biochemist, but it's a sugar alcohol, so it's not a pure saccharide. I mean, sugar won't do the same thing. So this is a sweetener with essentially no calories, and it works as a sugar alcohol. And since the biofilm is largely starch or polysaccharide, it works as a detergent. So it's scrubbing away at the biofilm and releasing.
It's the same way a detergent would with the fat on your dishes.
Right.
Yeah. You've talked about antibiotics and biofilm, and you mentioned in passing antimalarials. Is there anything you want to add about how you treat co-infections and how they complicate the clinical picture?
Well, I think while mycoplasma and Bartonella can be transmitted, from animals or arachnids, whatever, I think I look at them as opportunistic infections, things that we have. I mean, certainly in the HIV population, you had a vascular phenomenon with Bartonella, thought to be Bartonella. Bartonella species causes cat scratch disease, which is very tough to treat. That can't be easily isolated and can't be easily tested for microbial sensitivities. I think, Sarah, I believe now that babesiosis is the difference maker. I believe it's the engine. I believe people can carry lots of spirochetes and their immune system won't be demolished or fail. But when Babesia comes on board, it blocks some of the immune response. It blocks TNF, and I'm sure it does many other things we don't know about. And it is a difference maker. And so much so that if I don't clear Babesia in my patient population, I know that they may improve, but only about 60% of their baseline, or 70% perhaps. They can't get better. So I look at it the engine. So we dedicate a lot of effort to use biofilm and a variety of antimalarials in combination. Again, it's about combinations here. And we believe, or like to believe, that we have synergy going on. And it's a slow process because, again, I discovered that Babesia lives in the biofilm just through a clinical experience.
Mm-hmm.
It's a slow process, and in our experience in our world, nobody else does this in the world. That some people are copying it, but unfortunately they're getting it wrong. And I'm not trying to keep it a house secret at all. I'd love to publish, but that's not possible. I can talk about it more in the UK if you like, but we see patterns and we follow our patients carefully. So I would say that once we get up to full biofilm overlay for the first several days of a 2-week program, for example, and we've melted away some of the biofilm, released the pathogens, and now they're in a kill zone the second week. We feel at full dose, if we can get 3 cycles with full dose, and certainly 4, we feel pretty good about the fact that the Babesia is gone. And you see clinically that the liver and spleen that were swollen to start with are now normal within 3 or 4 months of therapy. And the patient's starting to feel much better. It's a big difference maker. Now, we need to improve on our techniques because Babesia is the number one reason for people to relapse in our world.
Mm-hmm.
So in the rest of the world, people don't treat it adequately anyway. But in our world, we do, but we still have failures, and we're working on what we need to do. And you have to take into consideration all the drugs the patient's faced with, and some are unpleasant, as you know. And we're trying to do the most sensible thing. We're probably going to do a little bit more of antimalarial therapy mixed in with our step-down program, which features rifabutin and pyrimethamine and so forth. We're probably going to continue for a couple cycles just to be sure. And when someone comes in and they've done 3 rounds or even 4 rounds and they've been really sick, especially if it's the second time through, have had a relapse, now this is the second, and they're fine, they're feeling better, I just tell them, you know what, we're going to do an insurance cycle. we're going to do 1 more cycle, and they groan, and more Mepron. And anyway, but they say, oh yeah, I get it, insurance.
And do you find that Bartonella is similarly difficult, or is it absolutely babesiosis that drives, I know you referred to it as the engine, but do you find Bartonella an awkward co-infection or any of the others?
It's a noble adversary. Mm-hmm. It's hard to kill. It loves blood vessels. It digs into endothelial cells. It's vasculopathic, as you know. It also invades the brain, and we think that we can identify or tease out some folks who are predominantly affected with Bartonella, and we adjust our therapy accordingly. Um, the kit, there are a few clinical tips for Bartonella. If someone has recurrent, quote, scratch marks or expanding stria, these are vascular manifestations. If they have any kind of unexplained rash or redness of the tips of their fingers or toes, if they have exostosis, which is extra bone, so you grow, so on one of your digits maybe you feel there's a nod that is bone, that's exostosis, which is presumably mediated by stimulation of osteoblasts, so they actually make more bone. We think those are Bartonella specific, and we're treating Bartonella throughout the Babesia program, but not intensely, because it's hard to use rifabutin, which is my favorite medication. It's hard to use it in the mix with the Babesia. Mm-hmm. There's a drug interaction with Mepron for one thing, and it's just too much. And there's no, it's going to take 9 to 15 months anyway to treat the patient. You understand? Mm-hmm. So we have to accommodate the reality of the pace. And yet, having said that, we're only medicating 8 days a month. You understand? Mm-hmm. 8 or 10 days a month maximum. And we're giving patients downtime in the middle of their treatment. Actually, there's a day off, a couple of days off, and then they have a couple of weeks off once they get going. So we try to pace, and we look at our windows, which is the time off, and after a few cycles, especially after most of the Babesia is done, we'll see patients have blue sky days where their mind is more clear, they don't feel inflamed, they're a little more active. Some of the neurologic symptoms, peripheral symptoms, are less. Now, granted, they're still on neurotropic medication, and so forth and so on, but it's still better. And that's the pattern we see. That's our clinical patterns again. So we start to see that. If we don't see it, we start looking for, what's spoiling the broth? What's spoiling the broth here? Mm-hmm. So we see patterns, and we explain to patients, all we want you to do is get through it, and everything has to be manageable. We don't want to terrorize you. We don't want you feel ever frightened or uncomfortable. And that doesn't help anything. We don't want the reactions to be so intense they're unbearable. That doesn't help the immune system recover, because, Sarah, it's really in the end about purging the infections and reestablishing the immune dominance.
Mm-hmm. Once you get to the end of did you say 9 to 15 month period? On average.
I'm sorry?
Did you say on average it's a 9 to 15 month treatment period?
Correct.
Yeah, and so once you get to the end of that, you've mentioned a maintenance program. Are people on that for life then, do you feel they need to be, or do they eventually come off that?
They eventually come off. I can only see 2 years out.
Yeah.
In the most severely afflicted patient, they might go 3 years, but it's only 3 dosing days a month, and it's easy.
Yeah.
And at that point, I'm not expecting any reactivity. I'm expecting them to be fine on the off weeks, and they have to, early on, keep things in check. They can't be overly active or overly ambitious or unrealistically ambitious, etc. And but when a person starts to feel better, naturally they want to do everything they've been missing.
Absolutely.
And if patients can't do that, if we see, the first thing we'll see is they can't. If there's a failure, if we've missed something, so you understand, we're marching down, we're observing the patient the whole way. It's not like we just say, okay, butterfly, fly away. We're marching patients through. We have expectations, and if they don't meet them, we have to redirect. What's going on. For example, I had a recent patient, and this happens quite often, where there was, I just couldn't understand why the patient wasn't getting better. And come to find out in the last visit that there was spousal abuse going on for the whole time. And she left him and got a new number, a new email, new address, and I asked her how she felt. She said, "I feel wonderful." So, you never know. I mean, yeah. So that's a testament to the vulnerability and fragility of the immune an emotional response, if you will. I hope I answered your question. I drifted on that one, I think.
No, and I think it was an important tangent, so I think that was good. Thank you. With we touched at the beginning on patients, perhaps being not all patients necessarily being able to recover. If you take out the subset that have got other complications such as motor neurons and so on, do you think most patients that have not had genetic diseases triggered and so on, can they get better? What sort of percentage patients are you able to get into some kind of livable state again?
Well, excluding the motor neuron disease predominant patients, which we'll talk about later, I suppose, as long as they meet the POEMs and it's true. In other words, there is true support that's going on and on. They have that support, which is tough. It's very tough.
Mm-hmm.
And if they have all that, and we have some ancillary care that's affordable for them, finances are a big deal for the patient. So if they go to this one and they get infusions off-site, or they go to PT or that's all cost, right? Mm-hmm. And so I would say for the average patient with a confluence of encephalopathy, arthritis, and peripheral neuropathy, and multiple other signs and symptoms, our success rate to get people better, 80%, maybe 90, and then 90 would be we pick up another 10 if the patient will stay with us, and we can work out the obstructions that they may be experiencing. Mm-hmm. And of course, we're learning all the time. I mean, we were one of the first ones to look at CCSVI, which I'm not going to go into, but look at that as an issue. We were one of the first ones to learn how to control seizures with combination programs. And of course, the biofilm issue, which is the key, and which we originated. And I understand Horowitz put that in his book and didn't give me a call, but anyway. I haven't read any of his books, by the way. We were the first ones to use combinations and pulsing. And I think this is all derived from my HIV experience, understanding that it's a totally different pathogen, but some of the principles remain the same.
Mm-hmm. That makes entirely makes sense. Did you want to touch on motor neuron patients now? It might be a good point, given you've mentioned.
Yeah, that's a tragic situation, and I think just tragic. So, of course, it's called ALS. Lou Gehrig's are everywhere, so they go to a medical center. But then they know someone or get online, and they say, "Well, could this be an infection?" So, Sarah, it's about our genetic codes and the way we detoxify and methylate. And as an aside, we do genetic screening and reports on those patients we know are going to be tough or are tough, because we want all the information that we can possibly get. Mm-hmm. And we employ that more and more. So back to our motor neuron, I call it motor neuron predominant borreliosis. Unfortunately, the cervical cord seems to get hammered. So you often have a patient who has good mental clarity, but they have wasting of their neck and upper back, where C3 and C4, cervical third root, cervical fourth root, are involved. So you get wasting in the traps, the scapula, the subscapula, the deltoids, and then of course as you go down C5, 6, 7, 8, T1, you get destruction and wasting of those motor neuron fibers that innervate the arms. So you'll see interosseous wasting. You'll see visible wasting. Sometimes this is more upper motor neuron, where the patient is spastic, and sometimes it's more flaccid, where it's more lower motor neuron. And it can happen in all the extremities. And of course, it affects the brainstem a little higher up, and so there's problems with swallowing and speaking and moving the tongue, because that's controlled by the 9th and 12th cranial nerves. Patient may not have a gag reflex anymore. They may choke or develop sleep apnea to complicate. So the whole key here is, do we treat these folks? Yes, but we don't treat them if they're in an advanced state because we can't help them.
Mm-hmm.
We may give them we give them a range of supplements. Deanne's protocol, you may be familiar with. We modify that and make sure they get supersized for their replacements as long as they tolerate them. Anabolic agents and so forth and so on. And the theory behind this came from Sadecki, who's a neurologist at Northwestern. I'm not sure where he was before. And a few years ago, and Sadecki is Q-U-E, and I've probably misspelled that. It probably is two D's. Anyway, if you look up Sadecki and ALS, you'll see his theories. He and his researchers found a protein called ubiquinol 1, which is a waste product in the neural tract, in the motor neuron tract, apparently. And it can't. There's some genetic issue that it can't be excreted. And when it can't be excreted, there's autonecrosis, and you get more destruction of the neuron. And I'm not sure why the motor neuron is selected in some genetically predisposed patients, but it is. But there's infection in there. And in fact, these patients have numerous other neurologic and systemic infections. So you'll find sensory things which you aren't supposed to find in ALS. You'll find autonomic and GI, and you'll find joint. You'll find all rashes. You'll find all kinds of things that scream at you that this is Berlioz' complex, but in a genetically predisposed patient for motor neuron dominant disease. And it's very, very sad. If the patient can still feed themselves and swallow and raise their arms and has a grasp and has good inspiratory effort, we'll treat. And sometimes we use IV, and the patient wants to do that. We have to be very cautious because it's like you're burning a rope at two ends, And so if we go slowly and we just assess the die-off, because when you have the die-off, what are you doing to the neuron? You're creating more inflammation and more ubiquinol, right?
Mm-hmm.
And so it's touch and go, touch and go, touch and go. And so we're desperately looking for gains of strength. I've seen it. We've done it. But the patient has to come in early. And unfortunately, the typical story is that, there'll be weakness. They can't play tennis. They can't walk the stairs all of a sudden. And then they have trouble brushing their teeth because their strength. They can't raise their, et cetera. Maybe start choking. And then all of a sudden realize that they're losing muscle. Or their one extremity doesn't work at all. And they get evaluated and diagnosed with ALS. And now we're 8 to 10 or 12 months into it, or a year and a half into it. And by the time that oftentimes by the time they come to us, they're another year down the road, and it's, it advances rapidly. At some point, it just takes off after, folks can be stable for a year or two, or a year and a half maybe, and then all of a sudden it takes off. And then you get accelerated damage to the motor neuron tracts, more muscle loss, more bulbar symptoms, and so forth. And becomes, as I said, if the state is advanced, we'll just do palliative therapy, mainly with nutrition and supplements, and maybe some oral antibiotics in very low dose combinations and frequencies. Because it drives me mad to know that the patient is infected and you can't do anything about it.
Yeah, I can understand that. Do you have other patients that you find you have to start very, very slowly and very sensitively with because they're so sensitive, even if they don't have a genetic predisposition?
Well, they usually do, though. So I think that reverts to gut health and dysbiosis, which we're learning more about.
Mm-hmm.
Histamine can be a major issue. You have to figure it out and think about it. If a patient comes in with multiple sensitivities, and I'm talking to drugs and food groups.
Yeah.
I'm not talking about multiple chemical sensitivities, which is a brainstem, limbic, thalamic-based issue. But on the other hand, if they can't take any of my neurotropics and they can't take any of the psychiatric meds which might help them. And mind you, I just don't willy-nilly put patients on antidepressants. And if they can't eat anything, they're going to be a challenge. And so we have to start very, very slowly. And there's a similar pattern with patients that come to us on narcotics, lots of narcotics. And of course, they don't work at all or very, very poorly. But the narcotics become a problem. And I've had that young lady who went to a center and came out like a flower. I mean, it was amazing. So that's another example. Again, this is in the framework of the poems. This all has to be. I like to tell patients, you know what? This is a difficult disease. It's complex and it's devastating, and all the arrows need to be going in the same direction.
Mm-hmm. Absolutely. I mean, you wouldn't build a house if you didn't put foundations down first, though, would you?
No, that's a good point. That's what we do when we stabilize the first few weeks. We put down a foundation. I've never thought of that way. That's good. I may steal that from you.
You're welcome. I know there's differing theories on this, and obviously people approach antibiotic treatment very differently to you as well. But what do you think herbal treatment has a place in treating Lyme, and have you seen that being done successfully?
I'm sorry. What?
Herbal treatment, sorry, or alternative treatments.
Oral what?
Herbal or herbal? Sorry.
Oh, herbal.
It's the English accent.
Herbal. Well, so I don't like cemento or cat's claw or banderol. So the herbalists have written these books, and there's some good things in there. But I would make a couple of points. Basically, they're dividing a group of herbs which have some beneficial effect for cell repair, but mostly as antioxidants. And then on the other side, they want to use mushrooms and other things like cat's claw. And we know that the cat's claw can kill the spirochete in a test tube and rev up the immune system. Maybe banderol can as well. However, it is confounding, and it's not something you can predict, and it's not reliable. So we have no idea what the parameters are. Whereas, so I'll use herbals. Our patients all take herbals, and we sign off on all of them, and we say, okay, now you're taking 8. That's probably adding a 9th is you're getting diminishing returns. I think we have some favorite herbals, and we encourage that. We absolutely do that. In addition to dietary changes and so forth, coconut milk, kefir, matcha green tea, glutamine power if it's tolerated, Hershey cocoa. So yes, we do a lot. I wish I had a nutritionist. When I was in Charlotte, I had 2 of them. Not just to help the patients and spend special time with them, but our patients do pretty well. So we use several herbs, and then patients are constantly bringing me new ones, and I look at it. What I don't like is when I'm not mad at the patient or angry with the patient, but I don't care for a product that has packaged 45 items in it, because I look at those 45 things as being medicines, as drugs, and I don't like that. I prefer to take things separately and evaluate them separately, and I think that's smart. Now, so we don't need antibiotics in some patients if they're not very ill. If their inflammatory meter, oxidative stress needle, if you will, is only off to the side a bit, they often compensate by getting rid of the inflammatory component in the form of food. You do that on the front end, so you don't promote inflammation through your gut. They take a few antioxidants. They make lifestyle changes. They may do yoga or meditation or exercise, which you're able to do because if they're not terribly ill, you can exercise, and that's a tool for detoxification. And they've heard about or learned about saunas or salt baths and so forth. And I love acupuncture. I'm fine with massage, if it helps. So the whole society is modifying their behavior because they're unwell to some extent, and so they said, well, you know what, I went off gluten, I feel fine. Well, they're going to feel fine for a very long time, or maybe not, you know, but because that needle goes past a certain point, the immune system has lost the battle. It's making noise, but it's not controlling anything.
And some patients can get it back in charge just by lifestyle changes if they're not severely unwell.
Correct.
Yeah.
Because not everybody needs antibiotics. We are not an antibiotic mill.
A factory churning them out.
We're not a factory, please. I mean, I've been accused of that. We're not.
Oh, have you? I didn't know that. That wasn't a slight at all.
Antibiotic. Well.
Yeah. Okay.
It's like saying you can treat AIDS without antivirals in a way. It's an extreme way. Or you can treat a sepsis without it. Just give them fluids and some dopamine for the blood pressure, and that's an extreme, probably not fair example, but it's ridiculous. People worry about the antibiotics. Well, we're very careful about pulsing, taking advantage of the targets, their slow replication, their life cycles.
Mm-hmm.
Giving people time off, supplementing the gut the best we know how, taking time out if things become too unstable, and using combinations. So, yes, we change gut flora, no doubt, but the gut is a mess to start with. And if there's mutation, we know that a mutated form is much less viable than, all in all, than a wild type form, because it's expending genetic energy to mutate. And once the pressure is taken away, which it is on the off weeks and etc., as they replicate, they're going to go back to the wild type because they're more they have better survivability. They're more capable of replicating, and they're healthier, if you will.
And do you have a similar approach when treating children? How does it differ?
Children do have some differences. Of course, we're working always closely with both parents, and I think that's a point to make. If you don't want to get into treating children if one parent agrees and one doesn't, because the one that doesn't agree is going to find plenty of opinions that what we're doing is quackery, and we're going to hurt the child.
Yeah, very difficult position to be in.
So both parents have to be on board, and they usually are, and they're very thankful. And this whole issue of pandas and kids, where the OCD, I think we see more of that. I attribute it to Mycoplasma, Bartonella, and the spirochete, but I'm not really sure that the Streptococcus has much to do with anything. I think it's just a epiphenomenon, serologic epiphenomenon. But I would say we see a little bit more OCD. We've currently lost Tara, and she won't be replaceable, but we'd hope to get a skilled pediatrician because she knew everything about life development, the markers. She knew that very well. She had a lot of knowledge about child development and so forth and so on. But yes, we treat children the same in many ways. The combination therapy, and we can't use the quinolones in children, but we're not really afraid to use the tetracyclines. And children get babesiosis too. Children get gallbladder disease too. Taking out gallbladders in an 11-year-old. Children are quite frightened and lost and don't understand. And if you get into teenagers, sometimes the disease. So if you say someone's infected early in life and they get the coalition going with Babesia and everything, let's say that happens, or let's say they have inherited borreliosis and then they acquire Babesia or whatever. I'm not sure that Babesia is transmitted, but it probably is, but not routinely. And their development is normal for a few years, but then maybe, especially just before puberty, as you go through puberty, you're going to see some expression of illness. You may get strange rashes, joint pain, unusual fatigue, sore throats, just things that shouldn't happen, nobody can figure out. And then adolescence is just all over the place, the adolescent brain. So I would say they're a special challenge.
I can imagine. I mean, teenagers are a challenge at any point. I know I was when I was a teenager. Yeah. So when you've got infections on top of that.
Mm-hmm. Right.
You touched then on congenital transmission. What are your views on Lyme disease patients having children, and at what point, and supporting them through that pregnancy?
Okay, so that's a good point, and I'm working with Georgetown University, just having a casual conversation with the academician there. We've changed our program a little in the last 3 or 4 years. Now, I have had, when people ask me, the patients are so sweet, and they're happy to get better, but, can I have another child? Or I want to have a baby now. Can I have a baby? Dr. Jemsek, can I have a baby now? It's like I feel like, I shouldn't answer. I'm tempted to answer this. I have fun with them. So, they're treating me like, you're on high here. You're going to say, I can have a child or I can't have a child. But seriously, and I'll say, in joking with them, and the husband's always there, by the way. And I'll say, joking to them, sure, you can have a child, and here's what we're going to do. But if it's a boy, you have to name him Joe. It's a good laugh. Always a good laugh. So, preferably, we'd like to have somebody deep in remission, right, or even off therapy, because the healing has occurred in the second and third year, and preferably, but it doesn't always work out that way. So, I happen to think that there's a much higher incidence of miscarriage in our badly infected females. Mm-hmm. And I firmly believe it's congenitally transmitted. And as you track our children through their childhood, you can sort of see that. We've identified a few things which aren't published, which we think are harbingers of more trouble ahead, basically involving the limbic system, which is destabilized in the growing brain. And those would be things like bedwetting, excessive bedwetting, sleepwalking, headaches, prepubertal headaches, especially in a male. Things like that we identify, we think the child is already infected. But, so the woman conceives, and we hear about it, and we've often had a talk, usually we've had a talk ahead of time, saying what we're going to do is I'm going to work with your gynecologist, or obstetrician, and we're going to work on the theory that we want to reduce the infection burden to the fetus. And we don't know how to measure it. It can't be measured. We don't know the risk, but I think it's pretty high that the spirochete's going to be passed. And we're going to put you on fetus-friendly drugs, which consist of amoxicillin or ceftonir, probably cefuroxime, and azithromycin. And I used to do it. I've been doing this for years. And I used to do it 3 days a week, starting in the second trimester. And then I had a couple. And then at the end of pregnancy, the cord blood is taken and checked, and the PCR is done for Borrelia. And out of 150 ladies, out of the first 75 ladies, I had 2 positives. Then I changed my technique to go, after talking to the academician, I went, as soon as they conceived, I went Monday through Friday every week. Not terribly high doses, but mind you, Zithromax just once a day. And very good tolerance. I mean, there's no problem taking the medication with the ladies. And I've had 1 positive since then. Now, the children that were positive didn't have any overt congenital defects. And, of course, that can happen. I do have a lady in Tennessee who became pregnant, somehow, got through the pregnancy and delivered, and her child had tracheal issues, stenosis, feeding issues, just intolerance, just a nightmare. Unfortunately, the child is 4 or 5, but was in the ICU on a number of occasions. So there's no question. And so we have fellows here in the United States, particularly a couple of pediatricians who I call village idiots, who can't make the cognitive leap from the fact that Borrelia is at the top of the spirochete chain. It's king of spirochetes.
And if syphilis
and somewhere
can
in the
pass,
middle or
then...
down low is syphilis.
Yeah.
So make that cognitive jump. And they deny it because they can't, they don't understand the I think it's just by default, it's denial due to ignorance. It's into the black, into the convenient black. Let's deny it as long as we can, because we don't want to terrorize the population, and we don't understand what to do anyway. We can't measure it, et cetera, et cetera. So that's our approach. And then we allow breastfeeding, but we ask the pediatrician, who's not as friendly usually as the obstetrician, to allow the mother to continue with her antibiotics, and we give the child, or can give the child, probiotic drops. We've had no problem. And then we like I believe in nursing. I don't know what the optimal time is, but it's at least 3 months, maybe 4, maybe 6, I don't know. But I think that's important, very important. And so we allow the mother to nurse, even though in theory she could transmit that way. But I think the nursing outweighs that risk, benefit of nursing.
Yeah.
So that's our experience. And of course, it'll never be written up. But that's our experience.
And what about other transmission methods? I mean, I know there's not sufficient research, but what are your thoughts on sexual transmission or transmission through saliva or any other forms?
Well, having a few examples to compare with, notably HIV and hepatitis B. Hepatitis B is significantly easier to transmit than HIV. In the HIV world, you could have 100 sexual encounters, heterosexual encounters with a discordant partner, and on average, there's a 1% infection per 100 encounters. That's a lot of sex. And with male and anal intercourse, you have a different physiologic situation, and so you have a better situation for transmission. So the incidence there is more like 3% per 100 encounters. Given the premise that we're all infected with some spirochete, where there's a conundrum, right? I mean, you don't know what to do. So, I mean, absolutely, if I have a patient in treatment, male or female, there's a barrier protection throughout the whole time and for the next year or two, if they can do that. Now, if someone's done really well as an option to that, the healthy partner or spouse, if you will, who silently has the spirochete, but as well, we go to maintenance, which is 3 days a month, something like ceftonir, minicin, and Zithromax, or rifabutin. I prefer rifabutin. And then that's 3 days, Monday, Wednesday, Friday. That's typically what I do. There's some variation. Then Thursday, Friday, we'll do diflucan and flagyl. We'll do 3 days of xylitol, Monday, Tuesday, Wednesday. So we'll bring the spouse in as a patient at a nominal fee, just for the record, just to be legal, if you will. And the spouse will sign an agreement, and we will treat the spouse just as we'll treat the spouse with our step down, just as we treat our patient.
So at the point the patient goes on to maintenance, so does the spouse?
Correct.
Yeah.
Not perfect, very imperfect, but, it's an insolvable problem, actually.
Particularly if the patient's immune system isn't capable of tolerating something that perhaps the spouse's is.
Well, by then we know that that's not usually the case, but if that happens, we just have to make a minor adjustment usually.
I'm sorry, I've worded that not very well using the word tolerate. I was meaning if the spouse reinfected the patient's immune system might not be in a state that they can cope with that, whereas the spouse might be asymptomatic because their immune system is functioning better.
Yeah, so I think
makes entire sense.
Yeah, exactly. You're right. But I think I made it clear how fragile our patients are as they go through everything, right? And so they're still fragile when they come out, but they're feeling so much better, and they've started healing already. But they're still susceptible. I think an important point is if we've done our job and eradicated the pathogens in the biofilm 99.9%, and we've got some healing going, and we're controlling the sleep that still is a problem, and later on we'll take that medicine away when the brain heals, and we're controlling the pain and a couple of neurotropics, and we'll take that away when the pain is better. Anyway, we get to that point, then if the patient gets a tick bite, or if there is sexual involvement, and there's transmission, let's say theoretically, the patient can pretty much handle that. It depends how far out they are. I mean, we've certainly had folks conceive after one of them's been treated for a couple of years, and can't use barrier protection to conceive, right? Unless you do in vitro, whatever. However, if there's unprotected sex in the middle of our treatment, that's like inoculating the patient with the spirochete all over again. The immune system doesn't like that. Just like the immune system doesn't like flu shots in the middle of treatment or shortly after treatment. Mm-hmm. Anything that dysregulates or destabilizes the immune system because it's fragile. But I guess the ancillary point is that the patient will never, ever go back to where they started from. They just won't. They're way too far up the curve, and they may drop back 2 notches or so, but they can get back fairly easily in most cases.
Yeah, they'll always be fragile. And you started talking about the sort of infection rates with HIV being 1 or 3%, roughly. What were you explaining that because you were going to use it as a perhaps to extrapolate the potential risk? I know we don't know the risk, but the potential risk.
Well, the potential risk, I didn't answer. So I don't think there's any risk with saliva. Mm-hmm. So kissing and all of that, I think there's almost no risk. So if we have the examples of HIV, that's true with HIV, and with hepatitis B, even you don't transmit with saliva, and it's the most transmissible agent of all. Mm-hmm. It has to do with, and people with borreliosis don't use large bore contaminated needles, usually. So I think it all boils down to sex. And I think I have no idea what the risk factors are. It only has to happen once, Mm-hmm. And again, I haven't really identified a situation, or haven't teased it out, where someone has a tipping point where they've had, sex for a period of time, unprotected sex with a spouse or a partner, and got sick. I haven't teased that out, mm-hmm. But I'm sure it doesn't help. You certainly think
it's possible, yeah. And I'm guessing certainly through blood and organ donation as well, that we shouldn't be giving blood or on the organ donors.
Well, you know what? That's a good point, sir. My child, some people know that my little girl, we almost lost her to a nasty leukemia when she was 5, and she's 6 years cancer-free and healthy, wow. And 12 years old. So, but in looking at donors, and there's 6 million worldwide, well, this is the criteria, and it's the usual suspects, of course, and this was 7 years ago, or 8 years ago. So I looked at them. I was astounded to see that people with Lyme disease can't donate, or can't be a bone marrow donor. I was astounded. This was 8 years ago. So, I think what it is that people have a feeling that, this is transmissible, this is nasty, and we better just put it on the list because we don't want future lawsuits.
I don't know about bone marrow, but in the UK, after 2 weeks antibiotics, we're allowed to give blood.
Really?
Yes.
Okay. How'd they figure that
out? I'd love to answer that question. It's not something I'd be comfortable giving my blood to somebody, put it that way.
Not if you're actively infected and symptomatic, no. So I've had situations where one of my sickest patients, I've had it happen with other patients, which I highly recommend people don't get spinal taps. The diagnostic efficiency is miserable. What you'll typically see is elevated albumin and nothing else. You won't see cells or anything else. And what happens is there's so many spinal leaks and then you get patched with blood, and the blood gets into the CSF, and the blood is contaminated with Borrelia, and you get a upregulation of infection in the brain directly inoculated through the blood patch.
I've not considered
very clear
that
evidence
before.
for that in one of my sickest patients. Not recommended.
Yeah, I mean, I'd thought of it not particularly being recommended because of the risk factors and the low chance of it coming up with a positive test result, but I hadn't considered the risk of, that's just worrying. Okay, thank you for pointing that out. It's not something I considered, and I think it's important point for people to understand if they're offered a lumbar puncture, because that's not something that would be explained to them, I don't believe.
And yet every neurologist will say, well, we need a lumbar puncture to make the diagnosis.
Exactly.
Now, an exception might be when, not that it would change my approach, but one exception might be if someone has lots of plaques and white matter and is felt to be classic MS, which I still think is infection-borne. Including the spirochete, mycoplasma, chlamydia. Chlamydia may be a big player. If you really critically look at autoimmunity and MS, there are many articles that argue against autoimmunity as being the path for inflammation.
Mm-hmm.
And yet, it has, in the conventional medicine, it certainly hasn't caught on. They keep making new biologics. If somebody has plaque, which is nothing more than a proteinuria debris and clogging and lots of, Dawson's picture with lots of periventricular stuff and around the ventricles and this and that and the other, and they want to make a conclusive diagnosis looking at oligoclonal antibodies and myelin bodies, that's fine. Most of them are actually negative, but if they are positive, that really doesn't change anything. I think that's just a biologic spin-off, of a chronic inflammatory state. But I suppose on some occasions I could say, okay, just be careful with the tap. But that would be the only reason, certainly not to diagnose borreliosis.
And if you're already having a tap for another reason, then there's no reason why you shouldn't ask for the spinal fluid to be tested, effectively.
Yeah.
Yes. We've touched a few times on frustrations, I suppose, putting it mildly, with the wider medical establishment understanding and accepting Lyme disease in its chronic form, its treatment, transmission, and so forth. Are you carrying out any research yourself, or aware of any that might shift that balance?
I'm doing two projects here, but my issue is that I have to fund everything here, and it makes it difficult. And I'm actually reaching out for help for the first time in 11 years, and I'm having a summit with some of my patients. In fact, a physician from London, a friend of mine, is coming over to speak about the issue. He doesn't treat the disease, but he's well aware of it. He's very innovative, very good physician, and a friend. And at the summit, we're going to go over the long and short of it and see if some assistance and direction can be provided. Mind you, I'm inviting very successful people who certainly have failed along the way, but very resourceful, innovative, insightful. People I respect, and we're getting a group of us together, and some politicians as well, some high-ranking politicians. Maybe we're working on the White House.
Mm-hmm.
But anyway, we're going to have a day-long symposium, and that will be a kickoff, hopefully, to allowing me to eventually bring in a nutritionist, a social worker, and most importantly, a couple of medical research people and writers, because we're a treasure trove, for clinical reports here.
Mm-hmm.
And we have to capture the data at some point. And so I've just decided I thought about it for years and years and years, and I keep getting in one or more predicaments, and I keep having to deal with lawyers. And I just decided I'm going to ask for help. And so my personal goal is, and I'm happy to collaborate with whomever. So it's not all about Jemsek, if you understand. It's not just me, but I do think I have the best situation for generating data, the best situation anywhere, really. And so that's happening, but it's going to take another year and a half. It's going to take the end of next year. Also bring some academicians, some people I respect that are involved in this country who are dealing with conditions and recognizing that microbes may play a role. Fellow out in Stanford, fellow down in Florida, fellow at Vanderbilt. So it should be interesting that way. So the establishment is, can be very lazy to say, well, there's no good research, but you look at the work that Wormser and the Cabal do, and there was an attack article 4 or 5 years ago just attacking. I've been attacked in print in some of the finest magazines and papers around the country.
That's possibly a compliment.
It is a compliment, and to me that just means they're afraid. And
people
when
are
you
always
ask why
afraid of
patients
things they
won't
don't
change,
understand.
it's a complex answer. There's a group of doctors that know there's something there, and then they know they're wrong, but they have a hidden agenda, whether it's to get rich with a vaccine or whatever, and they've slow played the epidemic, and they're evil, and we all know who they are. But I think a lot of mid-level academicians and other doctors who just want to open their mind to it, and I think I read an article about this. Why won't doctors change their mind about something? You're supposed to be learning all the time and adapting. And I think most of it, the article went on to say, is about shame. What if Jemsek is right? What if these other people doing this are right and I'm wrong after all these years? I've been treating the patient for all these years. I think that's a leading motivator, negative motivator.
Yeah.
And I think that's a lot of it. On the other hand, the people at the top have not provided any sensible dialogue in print to help doctors who are trying to understand. And so they have no pathway to follow.
Mm-hmm. And there's lots of conditions to understand as well, from a primary care perspective, particularly.
Yeah, they're busy. They're doing other things. They're taking this and that. And they said Lyme disease. Well, so look it up here. Well, it says 2 weeks of this, and everybody gets better.
Yep. Now, many of the questions from our members we got asked repeatedly that we've gone through here, but the one that probably came up more than any other was whether you could ever consider setting up a clinic in Europe or the UK because of the number of people over here that do travel to yourself.
Absolutely. I've been thinking about it for 3 years. I'll be in Ireland looking around in mid-June, visiting Anthony Morris. I'll be staying in Killarney. I'm going to be joined by my English doctor friend later in the week, and I hope to meet some of the physicians in the area, and with luck I'll go to a university and introduce myself just to get things going.
Mm-hmm.
I'm quite serious about that, and I'd love to have a place in Killarney that functions as a clinic, and I just don't. I have to understand what the rules are. The Republic of Ireland is the most liberal one in Europe. I certainly can't set up anything in UK, right? And or Northern Ireland. Anything's covered by the NHS. There's just no other country, and so it's a happy coincidence that they are the one. So I'm very interested in trying to do that. If I fail, I fail, but I'm going to try.
Well, that's very exciting.
Again, it's going to be a process, and I'm going to go over there and try to make friends. And yes, I think that would be so much enjoyment for me personally just to do that. I need, I'm like everybody else. I need change and diversity, and happiness and to function. And I really enjoy seeing patients from Europe and other continents. So.
Well, I think many of our members will be very happy to hear that. And if there is anything that Lyme Disease UK can do, I mean, I don't know what that might be, but if there's any instructions we can make that you might be aware of or anything, then do let us know, because I think our members will be completely behind you.
Well, I'll keep you in the loop. I will. Probably need some help with funding just to get over there, because I'm not going over there to make money. I'll have to charge fees, but I'm not going over there to make money and get rich. That's not the idea. So I'll keep you in the loop for sure.
Wonderful, thank you. And I'm conscious of time, so before we go to the last question, is there anything you feel like that we haven't covered that you'd like to share with our members about either your treatment approach or Lyme disease in general?
I think just as a physician, it's so important to go in with an open mind with the patient. Don't dismiss anything they say, because it may become your next clinical sign or feature. And it's so important to establish a comprehensive review on the first visit and do a comprehensive exam and make a plan. And it's so important, I think, to tell the patient that if you believe it, which most patients, we can say this freely, because we've gone through the criteria for treatment and what the priority problems are to be stabilized and so forth. We can tell the patient, you're going to get better. And I forget to say that sometimes. And the patient is overwhelmed. It's been 2-hour visit or 2.5-hour visit. All this information, they spend a lot of time getting things together, and it's just an overwhelming experience. So we try to be very sensitive to that. And if we believe it, which is the most of the time, we'll say, you know what, you can get better, but you have to be a good patient. You have to stick with the program, and we'll work with you. And it's not just our way to do this. You're going to help us help you. And I think that's very important and very reassuring for the patient, because the patient has to start off on a positive note. And you know the story. I mean, some patients have only been to a couple of doctors, but some have been to 2 or 3 dozen. And some have been ill for decades. Some missed out on life, most of the life. And it's heartbreaking. And then when the patient gets better, I wish we had a better venue for them to participate, and that's what I'm trying to do here, actually. Something they believe in to help, because our advocacy in this United States is splintered, as you probably know. Yeah. It sounds like you have a good, solid group, maybe the largest, much larger than anything in the U.S. So as far as advocacy, they're splintered, and many are dysfunctional. I think NatCap Lyme here in D.C. does a good job, but otherwise there's sort of a amorphous, aimless goal for some of them. But the patients want to help, and I've treated many influential people. They want to help. How do you help? Well, I don't really have a vehicle or a venue for you. So, with God's grace, we'll perhaps have something like that. And this will definitely be discussed at our meeting in September. We'll have a venue for people to invest in and to one day train doctors by the dozens at a time and get certification, create a college.
Fantastic.
Have a clinic, have multiple disciplines, have research, science, and clinical research, have marketing, have legal help. This can be done. It just, if people believe in something, I know they'll support it. And if they think it's going to make a difference, I think certainly here people feel like, well, I sent some money, I just don't know what they're doing. And so at any rate, that's part of our long-term goal, and that's what I want to tell your group and your audience. It's very important that I am forward-thinking, and with the help of many, many good people, I hope to do that.
Well, absolutely.
Create a lot of physicians, not just one that comes in for 5 days for a week to precept,
Well, absolutely, and it's going to be, sadly, very much needed given the rise in cases that seem to be.
Oh yeah, this is exponential.
Yeah.
The awareness is there, and I think in the future, in a decade or so, our generation at least, I think any neurodegenerative disorder, of which we have way too many around the world, right?
Mm-hmm.
If it's not, if an infectious cause is not sought, it's going to be malpractice.
Yeah, and probably for autoimmune conditions as well.
Mm-hmm.
No, that's really exciting to hear, and it's great to hear somebody that's so forward thinking. So I guess just before we close, what would you say to a patient who feels there's no way out?
Well, it depends where they are. If it's at the beginning, I'll tell them how to get out. If they're in the middle, I'll tell them how to get out. And if it's further down the road, often I can still tell them ways out and point out how they're better in many ways because we track this, that, and the other. And the spouse will look at the patient and say, "You're better, honey."
I love that answer. Thank you.
And then, but if it's truly hopeless, not hopeless, but if it's truly, if we have a sticking point, we hold things up and try to figure out, okay, what the heck's going on here? Mm-hmm. We try to get our genetic information, as much information as possible. We do big labs again to make sure the outliers aren't crazy and they have thiamine and cortisol and any identifiable non-starter, whether they're not reporting pain as they should. There are reasons. So I'll talk more about this in the fall, but we're constantly looking for reasons. CCSVI is something that occasionally is a problem. And where the pressure in the brain is slightly increased, and it's just if patients can't heal, they get so much nerve irritation. So things like that, in a few patients anyway, where the internal jugular valve is not working, in other words, and so you get a venous pressure block, and it builds up just slightly, but enough to create havoc. I've seen that a number of times where procedures have helped. So we exhaust all methods, but honestly, if they've gone off the reservation and they've lost their support, I'll just say we got to take a time out, and we're going to do this for a while. And what do you think about just doing a very minimal program of suppression until you have a chance to get balanced again? And in the case where there's no hope, as with the motor neuron, I'll just say I don't think I can help you. In the case where symptoms are very mild, I'll say you don't need antibiotics. I think you just need to make some adjustments, and if this doesn't work quite well, then you can return. But honestly, if there's no hope, I will tell the patient, I can't live with myself if I'm treating somebody where I think there's no hope. Mm-hmm. And I'm honest about it, just can't.
And it sounds like for the majority of patients there is that way out, and it's interesting that at the end you come back to support, which is where we started and seems to be such a critical piece of the puzzle from your treatment approach.
I'd like to write a paper on that because it's fascinating.
I'd like to read that paper.
Yeah, it's fascinating. There's articles written about this, that, and the other. Which spouse stays, which partner stays, which one leaves, why do they stay, why do they leave, what are the dynamics, is it a power thing, a codependent thing? Why do some spouses nurse the patient through for 2 years and then leave? I mean, it's just interesting. So the more we know about those things, the more we can predict them up front and have a good talk with everybody.
Wonderful. Well, thank you so much for giving your time up today. It's an absolute heartfelt thanks from everybody here at Lyme Disease UK. The people have submitted these questions and they'll be absolutely delighted to hear you answer them, I'm sure. So unless there's anything you want to add, I'll wish you goodbye and enjoy the rest of your day.
Well, Sarah, it was my pleasure, and I hope that your wonderful group is helped on some small level by going over this, and I thoroughly enjoyed it.
Absolutely.
I'll see you in the fall.
Thank you so much, Dr. Jemsek. See you in the fall.
And thank you.